will call you. Thank you, Serena, for starting recording. I will call you in alphabetic order by last name, but I'll call your first name, and I'll do the same for the healthcare provider and carrier members next. Let me start. Megan.
Hi, I'm here. Hi, Annalisa. Hi, everyone.
Hi, Megan. Welcome. Amanda. Allison. And reminder to take yourself on mute when your name's approaching. And if I go on beyond you, just say something if you come in late. We'll make sure it gets recorded. Jonathan.
In attendance, good afternoon.
Oh, very formal. Welcome, Jonathan. Bruce. Jason. Jerome. Thank you. I see Allison's here. Thank you, Serena. Chandra. I know that Leah could not be here with us today. And I know also that Lee Chow is going to be late. So hopefully she may come in later today. Josh. David. Anna.
If it's me.
Oh, hi, David. I see you. Thank you.
Hi, this is Anna. Good afternoon.
Hi, Anna. Good to see you. Hunter.
Hi, I'm here.
Hi, Hunter. Mark. Russ.
Hey there.
Hi, I'm here.
And Julie.
Here.
And Mandy.
Here.
All right, thank you very much, Data Committee. And Serena will be noticing, and sending, hi Jody, I haven't called you yet, but I'm glad to see you're here. Serena will keep track of people who come in late and be sure to get that on our attendance record.
Annalisa, Annalise Ross Lawerson here. I might have said hi for the wrong Ross. I don't know, you decide.
Well, thank you, Ross, for making sure it was Ross Lawerson. How about Russ Schust, just in case you didn't know it was you? All right, and luckily you're Ross.
I'm here. Couldn't get off mute. I'm here, Annalise.
Wonderful, thank you, Russ.
Annalisa, make us know I'm here too.
Terrific, thanks, Mika. I'm about ready to start on the healthcare provider and carrier list. So,
Annalisa, this is Mark. I wasn't sure if you heard me or not.
And Mark, great, thank you. I did not hear you. Appreciate you speaking up again. So for the health carrier provider and the healthcare provider and carrier advisor members, Mark. Bob, I see you. Hello, Bob.
Right here. Thank you.
Dustin. Paul. And hi, Jody. I saw your note in chat. Welcome. And Louise.
I'm here. Thank you.
Hello, Louise. Stacy.
Yes. Hi, Annalisa. I'm here.
Hi, Stacy. And Ross Lawerson, you already said hi. And Todd.
Hello.
Hi, Todd. And Vicky. Mike Marsh.
Here.
Hi, Mike. Natalia. Megan.
I'm here.
Hi, Megan. Mika, you already said hello. Hello, welcome.
Thank you.
And Dorothy.
Here.
And Wes Waters.
Hello.
Hi, Wes. How are you?
Terrific. Thank you.
Good. And thank you, everyone, and welcome to this joint meeting of our two advisory committees. The reason this meeting is joint is almost entirely practical. We have two presentations to provide that are both significant to the cost board, and they are seeking feedback from these groups, but they are two identical presentations. One of them is on the cost growth driver study prepared at the request of the board and per the legislative mandate of the board. by our friends at OnPoint. And Amy Kinner, the Director of Health Analytics, is here today to present to us that presentation. Now, those of you who are also following the board will realize it is the same presentation that was presented to the board. Now, I shared that with you in the email introduction to this meeting, and I encouraged you, if you wish, to listen to what the questions the board had. I will say they did not have a policy-based discussion around perception or what to do with this cost driver. The purpose of that, given the timing of the production of the report and the board's meeting dates, was to expose them to the cost driver analysis before the end of the year. So there is ample opportunity. Conversations about the cost driver analysis will continue for the ensuing months. So there is ample time to review this information and to provide feedback to the board about various perspectives that you might have, including how they should consider the data, what items they should consider for follow-up, how the data could be improved in the future, how the presentations could be improved, and then on into those deeper policy matters that I know we all are interested in as well. What kind of recommendations might be made to the legislature based on this, if any? So there is plenty of time for that feedback. The purpose of today is to see that cost growth driver analysis, to make Amy Kinner available to you to discuss methodology and presentation, and to begin the discussion and feedback to the board. And that's fair game, anything that you would like to share there. Then we'll have a time for public comment, and we also then have a presentation from Dr. Judy Zerzenthal on the first recommendation from the Primary Care Committee. And as you saw, I also recommended that for those of you who wish to follow this more closely or have deeper curiosity, the Primary Care Committee has gone through several meetings coming to this recommendation, including looking at all sorts of standards existing in Washington and the state and the United States, as they're required to do by their legislative mandate. And they are coming with this draft recommendation for the cost board. The point of the recommendation is for the cost board to ask questions and if possible, make a motion to adopt it as its first recommendation to the legislature. That's the Primary Care Committee's goal. Your feedback is an important part of that recommendation and will obviously inform the board about how they should consider it and whether or not they should in fact move for adoption as the board as is. And as always, on both of these topics, we will take feedback after the presentation. The board meeting is next week, so you don't have a tremendous amount of time to do that, and I apologize for that. But I will take feedback for the board up until Monday afternoon. So that's about as long as I can stretch it, but I'll make sure that it gets in front of them. So you have plenty of time to supplement your remarks and what you think after today. Does anyone have any questions on just that? When you can, what the purpose of the meeting is, what the presentations are, and how feedback will be accepted for the board? Okay, and as always, we take feedback by letter and by email, preferred in writing, of course, but however you want to present it. And we will also, so you'll see that primary care presentation is followed by a discussion, and then we will adjourn. So if there are no further questions, I'm going to turn it over and invite Amy Kinner to introduce herself to you and start her presentation. And Amy, I think we decided that I'm going to run slides for you. If I got that wrong, please correct me.
I think we did. So that would be great if you don't mind doing that. Thanks.
I don't at all. And welcome. And again, thank you so much for coming in front of our joint committees. And I'm going to, just before you get started, really encourage you. Amy's a terrific resource and knows a lot about the APCD and of course about the data that she is presenting. This is a great opportunity for you to ask your questions, technically, if the data, from the data committee and otherwise. So I'm going to ask Amy to we're going to watch for yellow hands. Please use your hands, and she'll keep an eye on it. I will interrupt and let her know if there's a question there she's not seeing, and we'll just go through the presentation with questions all the way through. Does that work well for you, Amy?
Yeah, and please feel free to interrupt me if you see a hand, so in case I don't see it. But yeah, that sounds great.
It takes a village to keep track, so for sure. They're little.
Yeah, sometimes you get in the middle and you don't notice those. So thank you. Yeah, so I can get I'll go ahead and get started. So I'm Amy Kinner. I'm the Director of Health Analytics at OnPoint Health Data. And basically we are, we build the APCD in Washington. I was involved with the implementation of the Washington APCD and other APCDs around the country, and have spent a lot of time working with APCD data. And when I was noticing that when I gave this presentation back in December 14th, I guess, 2022, it was completely dark out here in Maine where we're located, and now it's actually not. So it's almost dark, but it's getting a lot better. So that's a positive note to start on. So we appreciate the opportunity to present the findings of this first phase of the cost driver study. If you've already seen this, I apologize. It's pretty much the same presentation that we gave back in December. But we do appreciate the partnership of folks on this team, both Annalise's team and others who helped inform the methods of this. Next slide, please. So I'm going to start with an overview, and then I'll give you some insight into the methods we used in the cost driver study, and then we'll dive into some of the preliminary findings. And as we go through this, I just want to, mention that all of this it's a first phase, and we're already doing some additional work, and we'll be continuing to, look at the data, refine the methods as we go forward. So this is an attempt at getting something out there to start to look at these issues. Next slide. So the main purpose of the cost growth driver study, and I'm sure you're aware, is to just support the board's efforts using the Washington all-payer claims database to identify drivers of cost and trends in the healthcare system, and inform the board as it works to curb spending growth with its many different projects. This study will discuss the spend and trend by market, spend and trend by geography, spend and trend by health conditions and demographics, and potential unintended consequences. So we are tackling some of those in this first presentation, and others will be continuing to work on throughout this next year. Next slide. So the key topics for this phase 1 analysis: how has insurance enrollment changed during the last 5 years? How has spending, both total expenditures and on a per member basis, changed during those 5 years? How is spending changing for different products, like commercial, Medicaid, Medicare, Medicare Advantage? How does spending vary by category of service, inpatient, outpatient, professional, et cetera? Are there differences in spending by region? And are there differences in spending by age and gender categories? And how do high cost members impact spending? So we've started to look at these key topics, and then we're also working with Annalise and her team to develop a tool that can allow them to continue to dig into things that we're seeing in the data. Next slide, please. So I don't want to get overly focused on the details for this particular presentation, but I do want to give a brief overview of the methods we're using in this reporting. Many of those sync up with the data the board is collecting directly from the plans. For example, we're using the same categories of care, using the same age groups, and this will allow us to investigate findings from the benchmark data collection effort. So if that effort finds that outpatient spending for a certain population in a certain geographic area is growing, we can also use this data to investigate it. So that we've tried to sync up as much as possible. Next slide.
Hey, can I ask
So,
a question
yeah, sure.
real quick?
Yep.
Is part of the scope here, just want to understand, is part of the scope here measuring the trend against, I guess, the discussion that we had in the past about setting a cost trend, or is that out of scope relative to this?
So, Annalise, do you want to answer that question?
I'm not sure that can you rephrase that? I want to make sure I answer it accurately about the scope. Can you say that again, Ross?
Yeah, I apologize. So Annalise, so we spent months, I mean, a lot of time defining, setting a benchmark trend, right?
Right.
And I'm curious, a lot of time, a fair amount of time has passed now. So my question was, are we in measurement mode against that target? And is that in scope for this, or am I misunderstanding that this has sort of a different purpose? That was my question.
Thank you. Thank you, Russ. This is a different, so the cost board is required to do two things in statute. They're required to do the benchmark, which does, as you know, its own data call for a very particular type of aggregate data based on benchmark data calls that are happening across the country. So that is a new data collection and analysis effort. And we are engaged in that and anticipating bringing out the benchmark, which is that measurement against the benchmark set by the board in the summertime. This is a cost driver analysis done out of the APCD for now, but the statute also says, look, bring in other, it's really the beginning, as Amy said, of our analysis of Washington claims data. The benchmark does not use claims data. And so this is a separate parallel effort.
Okay.
I think I can imagine ways in which they can work together, but right now they're really pretty standalone, Ross.
Okay, Amy, sorry for interrupting your presentation.
Oh.
That, I think, Annalise, you just answered my next question, or my follow-up question, which was, when will we measure? And you say it's in the summer.
Yeah. When will we see the results of our first benchmark measurement? It will be in the summer. And reminder, just for folks who are following along, that that's a retrospective benchmark. We collected data from 17, 18, 19 on Washington's total health care expenditure and the cost increase trend. So it's going to measure things before there was even a benchmark in place. So really it's a baseline report that will be coming in the summer. But that's when we anticipate having it.
Okay, thanks.
You're welcome. And Ross, you don't need to apologize for interrupting. We all wanted you to do that. You set a fine example. Everyone do what Ross did. Thank you very much.
Although I was slow to put my camera on. There you go.
Okay. You don't, it's not a requirement. If you want to ask a question without your camera on, you can do it.
So the study looked at 5 years of data from 2017 to 2021, and that aligns with the cost benchmarking period. Next slide, please.
Although, as we said, Amy, it does go a little further into the future. The benchmark stopped at 19, but we got more contemporaneous data for this cost driver analysis. So it's the same period plus a little bit.
Yep. All right, so we had we have multiple product types and markets that we're looking at: commercial, Medicaid, Medicare fee-for-service, Medicare Advantage, the Public Employees Benefits Board, and the Health Benefit Exchange. And we are not looking at dual eligibles at this time. So for commercial, we have most of the a lot of the commercial population, but we do not have data from self-insured plans as part of a Supreme Court decision called a Gobey decision. The self-insured plans were exempt from having to submit to state APCDs, including in the state of Washington. So
Amy,
we don't.
Amy, I see a question from Wes.
Hi, Wes.
Yeah, actually, let me let her go through the functions tab, and let me ask the question after she gets through, if that's okay. I just kind of prompted my hand up too early. Thank you.
You bet.
Okay. For Medicaid, we have, so just going back to commercial, so we have the bulk of the commercial population, but we are missing that self-insured data just due to not being in the APCD. We have Medicaid data, fee-for-service. We are not including at this time. The fee-for-service data in the APCD don't have line level payments. So that makes it a challenge to look at things like primary care, which require procedure codes at the line level. We have Medicare fee-for-service, but at this time we only have that through 2019. We're hoping to get some additional 2020 and 2021 data in the upcoming months. Medicare Advantage, we have all of the data covered by commercial plans, but the pharmacy data we have not included because many of those members seem to have Part D. So the pharmacy data is a little bit of a mismatch once you get past 2019. We have the PEB data, both commercial and Medicare Advantage, and then we have the health benefit exchange commercial data. For dual eligibles, we have not broken those out separately in this analysis due to the fee-for-service data not being available beyond 2019. So it makes it a little difficult to look at dual eligibles, but that is something that obviously they're an important component of spending, and we would like to find ways to incorporate them in the future. Wes, can I answer any questions?
You can. If I can focus on the Medicaid line for just a second, there's some material exclusions there that would tend to skew the data quite a bit as it relates to Medicaid trend. If you're just looking at whole dollars, for example, in 2017, there was one region that was integrated. By the time we get to 2021, that has changed dramatically, which means that the amount of volume or total spend that goes into the program increases fairly significantly year over year, and it manifests itself as, if you're just looking at total dollars or even PNPM, primarily total dollars, that skews because the dollars will jump, and it looks like that's kind of incorporating itself. Can you speak to a little bit of that, or program changes, and how? I also see that line level payments, I'm assuming that's capitation, bulk payments, things like that are excluded from the data. Can you speak to how those things are called out in the analysis, or how those assumptions are clarified so there's not misinterpretations of the data as we're looking at that?
Yeah,
Or
it's just
being
so
viewed?
to go back to the line level payments, that's not capitation necessarily. That's it's basically the way the data was submitted is not the cost data for the fee for service data is not actually usable. All of the line level payments are put on it. The header is put on every line. So until that can be fixed, then we really just can't use that data for cost reporting. Unfortunately, that is something that has been fixed, but it was not fixed retroactively. So 22, 23, 24, we will have the ability to use fee for service data, but I don't think there's a plan to fix that retroactively. So yeah, so I guess, in terms of there being a mismatch of people shifting from plan to plan, that's the first time I had heard of that. So that would be something to like dig into a little further to see if that is impacting the analysis.
Yeah, for example, what I'm speaking to is like the integration of behavioral health care, where it was taken under one agency, and now within the Medicaid line, it's within the managed care purview right now. So fee for service or outside payments are not included if it's not an apples to apples comparison year over year. And I'm trying to understand kind of that. But going back to just the header data, is there some qualification or some quantification that shows what materiality that has on the data with line level versus header level? So as we're looking at it, this is like at a very, very, 100,000 foot view as I went through the presentation, but some of those details matter, and I'm curious how those get incorporated into the overall presentation so that someone looking at it can understand and know what limitations. For example, the state does a really good job. HCA does a great job working with Milliman, and they outline their assumptions at a very detailed level of what's in, what's out, program changes, benefit changes, all those things that change materially over time. They do a great job of calling that out. And I think, those provide those details to help somebody that's using the data use it in the context in which it was intended, or at least the assumptions to understand how they may skew the overall trend or the numbers. So that's kind of what I was looking for, is where those like assumption tabs are, or where those footnotes are that would leave a reader not with the impression that trend may be driven by something other than true actual period over period trend. So I'll leave it at that, but I think there's a lot of things that gave me pause when I looked at it, just to understand what's underlying the data.
Yeah, and in terms of the behavioral health, we have broken out behavioral health separately in this first presentation. We haven't dug into that, but that is something we can look at. Medicaid behavioral health versus non-behavioral health. We have that broken out separately, and we also have we do have a specs document that we provided to Annalisa and her team along with this that has kind of very detailed which procedure codes are included in each category, how we defined everything. So that kind of should accompany with this.
And Wes, I'm happy to post that and send it out and provide it. That's a good call that should have come out. So we'll make sure that happens. And your discussion, I just want you to know that your discussion about like what is inherent in kind of the baseline. So what's cost trend versus additional services, and behavioral health expansion and Medicaid is a big one. Adding certain populations is another one. We do need to do some analytics about that. You're right. I mean, I've been talking with Megan, who's also on the data advisory team, Megan Atkinson. She's doing some thought about how we can use data to better inform that discussion, at least certainly in the Medicaid part of the analysis about what that trend is. But that's going to be a challenge overall for every trend line that we have on PMPM. So I wanted to highlight that because that is a great thing to bring up. Every entity will have its contribution to make about what this trend line means and what it doesn't mean. So, and that's an important thing for the board to understand and for our state to understand going forward. We don't want to make assumptions that aren't true. We want to highlight the problem of increasing costs, but also understand what's making it happen. So I'm glad that you highlighted that concern. I know Megan has it as well.
Yeah, thank you so much for focusing in on that. I just think it's important when laymen or folks that are outside of this industry look at it, like a legislator or someone even from the public looks at the data and see the trend number, they focus on the number, but may not understand the analytics behind normalization of data as it goes into it. And I think that's incredibly important. I think the HCA does a really good job of normalizing the data and looking at those things. And having Megan on that committee is really, really beneficial. So thank you so much.
Great. I see another hand up, Amy. I see Mika. You have your hand up?
Yes, thanks. I think this is sort of a extension of Wes's question, but the restrictions or limitations that have been pointed out in the prior slide, so I understand that there are limitations to the data. The real question is, do these limitations change the interpretation? In other words, are the trends and the major areas of cost allocation different for the population that is going to be analyzed versus the total population? Do these restrictions limit our ability to apply what we've learned from this subset to the overall set? I presume you will comment on those, but I didn't see that in the slides, and I wanted to highlight that's a question that came up as you were going through these limitations for me. Thank you.
Thanks, Mika. Any other questions at the moment? All right, Amy.
Okay. I think maybe we might have gone the wrong way, or did? Okay.
No, well, so people will point out that this is, I am still, so we did purpose, we did key topics, we're doing summary of methods. We got past this slide. Did we get past this slide? Or are we still on?
Nope. I think we're past that one. Let's go to the next one. All right. So
thank you.
Categories. We align these with the cost benchmarking initiative. So we basically took the spec document that was provided to the health plans or the submitters so that they could submit their data on benchmarking, and we mapped these data the same way. So we have hospital inpatient, and that's facility payments, hospital outpatient. Again, that's on the facility side. The professionals come in as PCPs. We use the Washington narrow definition of primary care that OFM and a work group developed a few years ago. We have specialty providers who are non-PCP physicians, and then we have this other provider category, which was defined as other professionals like physicians, assistants, nurse practitioners when they're not doing primary care. occupational therapists, counselors, community health centers, freestanding ASCs. And then we have the long-term care SNFs, hospice, home health, personal care services, pharmacy claims, and all other dollars. And so this was, we basically tried to use what was being used for the other parts of the benchmarking initiative. We developed detailed specifications, which are in our spec document down to the CPT and taxonomy code of what went into what. So if you're more interested in, actually what was going into these categories, there is more information on that. But from a high level, these are the categories we're going to be looking at. Next slide, please. All right, so limitations, as I mentioned, the self-insured are not required to report data to the APCD. And of course, we don't have the uninsured in this analysis because they don't have claims. Medicare fee-for-service is available only through 2019. So we'll see some data on Medicare fee-for-service, but because this analysis goes through 2020, many times we do not use the Medicare fee-for-service. We don't have the alternative payments like capitated payments, pharmacy rebates yet. That would be something we would love to add in the future as it gets collected. And then we don't have long-term care data for Medicaid. That's not reported to the APCD, but it is a significant contributor to spending. And then Medicaid fee-for-service data. Next slide, please. So the story really begins with the membership. The Washington APCD has changed in membership over time from 2017 to 2021. And of course, that's going to impact the dollars that we see in the data. So next slide, please. So the dark blue is the total membership excluding the fee-for-service, and the gray is the Medicare fee-for-service members. And you can see there was a steady growth in the number of people in the APCD from 2017 through 2021. Starting in 2017, we had 3.5 million of non-Medicare fee-for-service patients, and then up in 2021, we have almost 4 million. So about 500,000 new members in the APCD, and we got Medicare fee-for-service from about 800,000 for those first 3 years. And I think I saw a question from Mandy. What year did SEB plans get added? I believe we just started taking in the SEB flag in 2021, Mandy. I think their data has always been in there, but they weren't identified.
SIP as a program, but a state administered kind of centralized healthcare program began with coverage in calendar year 2020. Prior to that, I would assume the individual, however the districts were purchasing healthcare would have gotten fed in, if they were a Primera plan or whatever. But SEB as a state operated kind of centralized program started with coverage in 2020.
Yeah, I think if you went back earlier, you'd see group names of schools and things like that. But yeah, we can't identify them before that period. All right, so next slide. All right, so we know the population was growing. My next question would be, was that because the state's growing? And it is true that the state has been growing, but the growth in the APCD is actually greater than the state population growth. So this shows a 1-year change of state population and also APCD membership. So for example, in 2018, the state grew by 1.6%, and that was kind of consistent from 2018 to 2017 to 2018, 18 to 19, and 19 to 20, and then a little drop down from 20 to 21. But general, steady growth in the state. The APCD membership did grow considerably at a considerably higher rate than that. Started at about the same rate, but then you can see in 2020, particularly, there was a spike in membership of the APCD growth. Next slide. So how did that change by product? Well, you can see the highest number of members by product is Medicaid. And we had about 1.5 million in 2017, and then in 2021, 1.7 million. For commercials, pretty much steady. And then you also see kind of a jump up in the Medicare Advantage population. We see that kind of across the country where more people are enrolling in Medicare Advantage plans, and also a jump up in the exchange population. For Medicare fee-for-service, I just want to point out that that is 27 and 2019. There's not 2020 yet there.
Amy, did you see the question in chat? Dorothy's asking does this data include about half of the Washington state population?
Yeah, I think it was about 4 million, and then another 800,000 if you include the fee-for-service. So I'm sure others have a better handle on the total population in Washington. I think it's somewhere 7 to 8 million. So sounds like it's about half, maybe a little bit more. Oh, but one thing I want to point out here is that actually the way we calculate membership, it's not distinct patients or distinct members. It's actually, we use in this analysis, member months of coverage divided by 12. So I think that's an important distinction, because you may see other numbers for Medicaid, for example, that are, at this particular month, we have this many people enrolled, or how many distinct people were enrolled during the year. What we're seeing here is that we weight it by member months of coverage. So if I am only in the state for half of the year, for 6 months, I only count as a half a person. So that might influence the numbers a little bit. And that is helpful when we go and look at rates. We really need to weight it by how long people are enrolled in insurance coverage. So can we move to the next slide? All right, so enrollment trends during this time were very much influenced by the COVID-19 emergency. If you look at commercial, Medicaid, and exchange, again, annual % change in enrollment, you can see before COVID public health emergency, Medicaid enrollment was actually declining. But then in 2020, between 2019 and 2020, we had a 7.2% growth, and then another 9% in Medicaid. We also saw a lot of people enrolling in the exchange between 2017 and 2021, high percentage growth every year. And for commercial, we saw sort of a decline. So I think probably a lot of what was going on here was during the public health emergency, folks were able to stay on Medicaid longer, and we know that's going to end in the future months, and it'll be a definite challenge once that happens, and definitely see some different changes in enrollment in the future. Next slide, please. So that's enrollment. So we know, more people in the data. We know that they shifted in where they were, what they were enrolled in to some extent. And we also know that expenditures have changed. So let's look at that now. Next slide. So again, this is 2017 to 2021. The dark blue is the total excluding Medicare fee-for-service, and the gray is the Medicare fee-for-service dollars. From 2017 to 2021, we had an increase in claims expenditures in the ABCD on the medical side from 11.4 billion to 16.2 billion. And then we had about another 7 billion in Medicare fee-for-service expenditures. So definite growth there. Next slide. And this really happened across all categories. This shows inpatient, outpatient, specialist, and so forth. And the light blue is 2017, the dark blue is 2021. So you can see sort of for each of these categories, there was an increase in expenditures from 2017 to 2021. We had inpatient as the highest expenditure category, but you could see outpatient is kind of catching up. So for going from 2.7 to $4 billion during this time. Next slide, please. And as a percent of total, it's interesting to look at some shifts that happened. We know they all increased to some degree, but that there was also some shifting as between the categories as their total composition. So
Amy, I see a
yeah.
question from Dorothy, and I want to make sure if it related to the last slide, I want to stop for a minute. Dorothy?
Okay.
Yeah, thank you. I think it's interesting to see the total expenditures, but what's more meaningful, I think, and what's going to create some meaning is the rate, total cost of care, and then the rate per person or the rate per something, because it doesn't, if you have more expenditures but more people, it seems like it may not create it, it's not really that helpful.
Dorothy, we're going to get to that in the next couple slides. So
okay, thank you.
That's going to be upcoming. So
thank you.
Yep.
And then I see a question from Louise Kaplan in chat. How does the outpatient differ from primary care in the last slide? Oh, I went the wrong way. So bad at it.
So outpatient is on the facility side. Those are the facility component, and primary care would be the professional fees to primary care providers.
Thanks, Amy.
Yep. So of the percent of total, we have outpatient that went from 23.6% to 24.9%. Other professional also jumped up from 13.4% of total to 15.3%. And other medical also increased. And then you can see inpatient actually decreased as a percent of total, of course, and specialists and primary care also decreases as a percent of total. All right, next slide, please. And pharmacy claims expenditures, similarly to medical, sort of gradually increasing over time from 4.6 billion to 6 billion, and another sort of 1.3 to 1.4 billion of Medicare fee-for-service Part D claims. Next slide. So yes, all of that is interesting, but it's not as interesting as Dorothy said, as looking at rates per person, right? So we know we have more people, we know we have more dollars, and we also need to look at, and actually I think dollars as a whole, it is important to know that healthcare spending is going up, in aggregate, even if there are more people that still, but obviously we want to know the rate per person. So now for the rest of the presentation, we're going to start to look at sort of the PMPM expenditures, the per member per month, and we're going to use really the total expenditures and divide that by the member months of coverage. So, all right, so this is total per member per month expenditures by year. It's all of the payers. It does not include the Medicaid fee-for-service, of course, or the Medicare fee-for-service, because they don't have the 2020 and 2021. So it's all of your other payers, including Medicare Advantage, Exchange, PEB, commercial, and Medicaid, sort of a blended total aggregate. In 2017, we had $271, and by 2021, we had $340. That's an increase of 69 average dollars. And on the bottom, we can see sort of the annual percent change, and you can see 2018, that was about a 3% increase from 2017, 8% in 2019, and then we had a dip down during COVID of 4% when people were probably staying home instead of getting their medical care, their surgeries and whatnot. And then in 2021, sort of came back to the medical system, and we had an 18% increase for a combined total of 25% over the period. Next slide. And similarly on the pharmacy side, I think we can start with the end point that we also had a 25% increase on the pharmacy side. And that was from $81 to $102, and a 21% a $21 4-year aggregate growth. We did not see the dip in pharmacy in 2020, which makes sense. People were still getting their prescriptions, and we also saw an increase in 2021, but not the same as with the medical side. Next slide. So now we know both pharmacy and medical. Oh,
Amy, we have a hand up. Jonathan Bennett.
Yeah, sorry about that. I just
worries.
had a couple questions on that just to get, you'd mentioned early on the high cost members, kind of the outliers.
Yep.
What was done there, if anything? I think that's going to obviously have a pretty significant impact on that one. And then I'm also curious about what other factors are considering with the cost over time. Was inflation part of that equation? How is that addressed? I think what Wes said earlier made a ton of sense of having some of those assumptions nailed down so we can have better context and framing of some of the numbers, because there are so many moving pieces that will have a significant impact on the way that they are, the outcome of them, on whether they're considered, not considered, what are the thresholds. And obviously, just for an example, outliers, the high cost members would be an obvious one there.
Yep. So we'll talk a little bit about high cost members at the end of this presentation, but to answer your question, we did not truncate or remove high cost members in this analysis. I know for the healthcare cost benchmarking initiative, they are truncating at certain levels to kind of remove the high cost members, or at least put them at a reasonable level. For this, we did not remove them. I think that decision was made mostly because we're also interested in them as a way of controlling costs. But as I'll show you in some future slides, they do comprise a significant portion of spending. So the way you might want to handle them is probably a little different. Mika, do you have a question?
Yes, thanks. For the total PMPM medical expenditures, a couple of slides back, there are, as you note at the bottom, some exclusions. Do you have a sense as to what proportion those represent? Are they a couple of percent, 20%, 50%? Do they have a big impact or a small impact?
For the Medicare fee for service?
Go back 2 slides for total PMPM medical expenditures. So it doesn't include non-claims payments, Medicaid long-term care, Medicaid fee for service, et cetera. And I'm just wondering, Annalise, if we can go back 2 slides. Yep. Okay, go forward there, that one. The exclusions down below, how do they, what proportion roughly are they of the figures that are given above? Are they a small percentage of it, or are they would they significantly add to those values? Do you have any idea?
I think I'd have to take that back and look at it. I know the Medicaid fee for service is a small, so we have the kind of the totals from that, and that's small compared to the managed care dollars. The Medicaid long-term care, we don't have that data, so we could from HCA get the information on that. And non-claims payments, I don't have that information because we don't have that collected.
So some sense of what proportion that represents as to whether it's a negligible thing would be helpful, and also whether those values are changing significantly from year to year and really throwing off all the analysis would be helpful. Thanks.
Okay. I'm going to go back. I think this is where we were, right, Amy?
Yeah, I think actually, yeah. So in terms of spending by product, so we'd be interested, now that we've looked at the kind of blended rate, in looking at, what each product, how each product changed over this time. And as you can see, Medicare Advantage has the higher level of spending in both 2017 and 2021. But of course, we know that those are people with more health needs, an older population. Commercial is a little lower, as well as exchange, and then Medicaid is the lowest. You can see there was growth in each of these over time, 20% for Medicare Advantage, 25% for commercial, 30% for exchange. Of course, we knew there were a lot of people coming onto the exchange, so perhaps that had something to do with that, and then 25% with Medicaid. And I see Megan has a question.
Yeah, actually, I just wanted to weigh in on a little bit on sort of the conversation that actually Wes started at the beginning of the presentation, Amy, sort of around the Medicaid, what we call program changes in the Medicaid side. And so just a little bit of background, and I just don't know how this compares to sort of the commercial side, setting aside the UMP population. But you know, when we build up, or when Milliman on behalf of the Healthcare Authority builds up the Medicaid managed care rate, we obviously have, you know, sort of incremental changes, right, from year to year. And of course, the rates are built up using, you know, a full set of new data, refreshed data. But we sort of lump in, for purposes of talking about the rate changes at a high level, we sort of lump in what we call program changes. And those can be legislatively directed rate increases. The Medicaid program has benefited from a large degree of legislative support over the last few years, with providing both targeted and what we in Medicaid call directed payments. Then also, as Wes talked about, the integration of the behavioral health services into our managed care program. I did a really rough calculation, and this is really rough and cursory, in going back over this period of time, the 2017 to the 2021 time, and looked at just our targeted program changes. And so things like legislatively directed increases. During this time frame, we carved pharmacy out of the managed care rates, and then we carved pharmacy back in under a slightly different structure. And so that 171 to 214, I think that's 40-ish, $43 on a PMPM. And just those targeted program changes are in that same ballpark. And I am not in any way saying that the targeted program changes are the totality of the difference that we see from 2017 to 2021, because we definitely also had, you know, medical trend or inflation in this same time frame, and that obviously also gets built into our rates. We also had acuity adjustments, we had the pandemic, we had all these things, right? But I do think as we look towards going down in sort of the next steps, it'll be really interesting, and I think really imperative on us to understand, to the degree we're able to. Medicaid's pretty straightforward in that it's all HCA largely. It is a defined program, defined population, and of course, you know, we have a lot of documentation and publicly available documentation on the Medicaid side. But I think it'll be interesting and again, imperative on us to sort of, to the degree we can peel back in the same way across these other segments, you know, what were program changes, increases in benefits, increases, you know, changes in the population, those types of things, and then get down to what was inflationary driven or trend driven, what was utilization driven, you know, some of those conversations, because it will be very difficult to really fully understand how well the state is doing compared to the targets of the cost board without that additional context, right? And again, the Medicaid program, we can peel the onion relatively easily. And I just don't know how well we'll be able to be comparative across sort of the lines that we're looking at there.
Yeah, thank you, Meg. I'm really glad that you brought that up, and I know that you are thinking about it. And I see your hand, Wes. Just before I go there, I'm going to remind people that the benchmark result is intended, you know, is intended to really prompt these kinds of conversations. It is at this point an investigative prompt tool rather than something that, you know, comes with FIP plans or penalties as it does in other states. And I'm aware that there's a bill about that. But what we want to be able to do is have entities that are subject to the benchmark assist us in exploring what that benchmark means and what performance is relative to the benchmark. It's not a benchmark score should not be considered a scarlet A with no further explanation, for example. It is the beginning of a conversation. And I think Megan is taking natural steps as a government administrator to say, how can I position myself to explain what that might mean? Taking that, understanding what data I submitted, understanding what data is not really being looked at, how can I lead that conversation of what my benchmark means? And that is, I think that's a great position to kind of take and start preparing for. It's because I know conversations about this will be occurring when that benchmark comes out. And thank you for letting me just, so thank you, Megan, for bringing that up. And I appreciate your being willing to look at the data and kind of help us understand what the application of the benchmark means to what's really happening in your lines of business. And now I will turn to Wes. Thank you. Your hand's up, Wes.
Yes, thank you. So this takes me back to a time years and years ago, 30 plus, I'm going to age myself a little bit in managed care, over 30 years ago, when I started in this, you know, it was basically HMO driven. And I remember when I had my first kid, I joked and I called him the $10 baby, because back then you had a $10 deductible for an HMO. And then 2 years later, I had my daughter, and I joke with her and call her the $100 baby, because by then the deductible went from $10 to $100. I am going somewhere with this, I promise. Fast forward, because I used to be on the commercial side, and one of the things that you do to help mitigate trend and make the products more affordable is you have to look at it from a benefit perspective. So on a benefit perspective, you'll see that programs evolve from HMOs to PPOs to, you know, for POS to PPOs, and then into HSA type products, right? So now you're talking about having a baby, and you know, you hit your deductible at the beginning of the year, and it may be several $1,000s out of pocket. So what you're doing is you're mitigating some of the medical expense trend, because total cost of care incorporates member COB, coordination of benefit. You know, you have member liability, you have coordination of benefits, all these things factor into the total cost of care. The reason I'm bringing this up is when I talk about it in terms of Medicaid and the program changes we have there, there's also benefit normalization that we have to consider as well for commercial products. There's also tier products, for example, on the exchange. So you go from year to year, one of the things that you'll see there is you have to kind of look at it from the standpoint of kind of apples to apples. You may have a strategy to go in with the bronze product versus silver versus gold. And each tier of that has a different level of member liability, member impact, but that also affects the trend of the product. So the more a member is experiencing out of pocket, the more they think about and become partners in the investment in their healthcare. So it can mitigate trend. It can also, you know, reduce overall total cost of care as you're sharing that with member liability. So I'm not on the commercial side anymore, but I bring those up to just suggest that when you're looking at the data and you're looking purely at a medical expense total cost of care without normalization, like I said before, and Megan did a great job of focusing in on things that happen with Medicaid, but it happens also with commercial and exchange. When you look at tiers of products, you look at benefit designs, you look at PDLs, you look at member copays on drugs, whether or not they're on an HSA and having to pay for the full drug in the first part of the year. That happens on the Medicare Advantage side. Early in the year, the member has more out of pocket. As the year goes on, their dynamics and spend changes. So all those things just need to be incorporated when somebody's reading data on medical trend, to understand that there's forces at play that go beyond just the total dollars or the PMPM that goes within it. So I'm going to pause on that and just kind of use that as a reinforcing of what I brought up earlier.
Thank you, Wes. So I'm noticing we're doing a great job of having a conversation while we go. I need to do public comment in 10 minutes. So Amy, I don't know how many slides you have left, but I'm going to change tactics just briefly. Unless you have a burning technical question, like what does that mean? Let's let Amy get through the rest of her PMPM slides, because I'd really like to be able to do that. And then whatever time we have left, and we can come back after public comment if there are additional questions. Okay, does that make sense? So we'll just hold unless you have something that you need explained right on that slide, and we'll march forward. Okay, Amy.
Right. Yes, and thanks for, all the great comments. And as we, I think, just mentioned, this is kind of a starting conversation, and we could go back into the data and see, what was I think the intention is to go back into the data and see, okay, were there changes in, products that people were enrolled in and things like that, or, what type of people are now on Medicaid compared to 2017 as the population gotten sicker, things like that. We can look at that, and this isn't the benchmark itself, it's really to the cost drivers analysis. So the goal is really to drill into those. So thank you for this really, it's helpful to get your insights into what could be driving some of these things. So PMPMs by category of service. I'm going to kind of start to go a little faster because I know we have used a lot of time, but you can see on the inpatient side, the increase was quite a bit lower than on the outpatient side. So we see kind of a shifting of dollars to outpatient. Specialists in primary care also had kind of a low rate of growth, as well as long-term care. The other professional, and if you remember, that was kind of like, it included ASCs, I believe, but also folks like chiropractors and nurse practitioners and things like that, has increased quite a bit. And then that kind of catch-all other medical area has also increased quite a bit. So it'd be interesting to go in and look and see what was going on for those categories. Next slide, please. And kind of drilling in by product to the PMPMs. So looking both at product and category of service, we have inpatient PMPM. As you can see, Medicare Advantage had the highest spending, which makes sense because those are folks who are more likely to need to go to the hospital, compared with the other products, which were quite a bit lower. But there were not huge jumps in spending for any of the products. Next slide. On the outpatient side, we do see much more significant jumps in spending, particularly for the Medicare Advantage product, particularly between 2020 and 2021, kind of a big leap up there. And then also the exchange seemed to have some significant growth in spending on the outpatient side between 2020 and 2021. Next slide. Next slide, please. Okay, on the professional side, these are all presented on the same axis, so you can kind of look at them in comparison to each other. Primary care remains quite a bit lower than specialty care, the spending for specialty care or the other professionals. You can see for specialty care, there's kind of that a jump after 2020 for the Medicare Advantage population. And also for some of the other professionals, we do see a little bit of a tick up. Next slide, please. And then in many of these types of analyses, you'll see sort of that percent change in PMPM from baseline graph, and then also looking at utilization and average allowed amount per service. So just kind of a crude measure of price. And so we can look at that here. If you start on the right, we can look at outpatient, kind of the growth from, so this is kind of a percent change from baseline. So the baseline is 2017. So it's kind of an aggregate percent change. So you can see the outpatient grew by 34%. This is commercial only. Inpatient, pharmacy 25% and inpatient 5%. And then if we go and look at outpatient across each of these graphs, you can see that the percent change in utilization on the far left for outpatient really was 32% change in sort of the number of services per thousand, and the percent change in average allowed amount per service did not grow considerably, was a 1% increase over this time. So on the outpatient side, we could say that in looking at this in a crude way, of course, it would be good to dig into what really was going on in a utilization and average allowed amount, but in a crude way, the change in PMPM seems to be driven by utilization. In contrast, for pharmacy and inpatient, well, for pharmacy, seems to be driven by a higher average allowed amount per service over time. And then for inpatient, not much growth in the change in PMPM, but where it was probably, there was a reduction in utilization and an increase in the average allowed amount per service. Next slide, please. So we also looked at regional differences in spending. Next slide. We looked at counties, and this kind of shows kind of variation between the counties for the different products. And in each of these dots consists of a county and the average PMPM for the members in that area. So for commercial, you can see there's quite a bit of a spread for exchange and for Medicaid and Medicare Advantage. There's a wide spread by county. It would be good to drill into some of these outliers and see what might be going on in some of these areas. Next slide. We also rolled up from counties to the accountable communities of health, which usually consist of multiple counties, and looked at between 2017 and 2021 how spending changed. This is on the commercial side only. And you can see in each area, spending did increase. In the Southwest ACH, there was quite a considerable increase. So that would be good to kind of dig in there and see what was perhaps driving that. Next slide. And just to mention that we know there are differences between areas of the state in terms of risk factors and age and gender composition of the population, and those are just crude measures. It would be interesting to look at, more detailed in terms of like people with different chronic conditions and whatnot by area, and we have the data to do that. By age and gender, we have this is showing kind of the variation in medical PMPMs across all plans by age and gender for 2021 only. And you can see the male and female groups, that 0 to 1 category, the infants and babies have a higher PMPM than your other pediatric populations, the 2 to 18, which is as the lowest. And then you can see that it tends to climb as you get to the older ages. Next slide. And on the commercial side only, we can look at the percent change from 2017 to 2021 and by age. And we can see that the pediatric population did not increase in spending as much as the older ages. So, and finally, we can talk about high cost members. So as I mentioned, next slide, please. We didn't truncate high cost members for this analysis. There are some a population we're interested in and would be interested in looking at more deeply. We quantified how many members had more than $125,000 in medical spending. We use that because the benchmark is also using that as a cutoff for many of the products. And we found that for each product, those high cost members comprise less than 1% of the membership, but 15 to 21% of the total spending. So significant portion of spending for every product is coming from the high cost members. And these are a very small fraction of the membership. Next slide. And just visually on the left, you can see the percent of members. The high cost is the dark blue, and the percent of the medical allowed amount. And you can see there is quite a difference in terms of the percent of members and how much spending they account for. So obviously would be interesting to drill in more to see, where the spending is going for these folks and what categories of care and what conditions. Next slide, please. All right, so the next set of analyses, we've provided the data to Annalisa's team. We're going to be able to drill into further areas of growth by product region and combinations of those, looking at chronic conditions, looking at spending for behavioral health and primary care. How do those vary across the state? How has out-of-pocket spending changed? Are there relationships between spending and quality and access to care? And how are utilization changes impacting spending, and how are price changes impacting spending? So we've built the data sets for those. We're building a tool for the team to look at those visually, and hopefully it will continue to get great questions that we can start to dig into using what we have, and also going back into the data and exploring and trying to answer these questions.
Well, thank you, Amy. Yeah, it's a very small list of things that nobody's interested in, those follow-ups. Joking, that's a tremendous amount of work. Every one of those questions has a lot of analytic work, and we're looking forward to doing that. I'm going to move to public comment, but first, actually, let me do this because, Amy, I know you're in a different time zone and you would probably like to go home at some point. Are there questions, urgent questions for Amy? I do see one pretty quick question. Does the pharmacy information you were sharing, pharmacy PMPM, include rebate numbers or not? So it's in the chat.
No, we do not have the rebate data in this analysis, but something we definitely want to be implementing.
Thanks for that. And we're getting high-level rebate information in the benchmark data call. That may be something that we can use. Mike, you have a question.
Yeah, in the spirit of getting Amy home, I'll try to be as quick as possible with this. I've really 3 comments really for consideration. First of all, when I look at a presentation like this, I try to think, what do I make of it? I mean, is there any conclusions I can draw from all of this information that feel like they lead me to some action? And one thing that would help, I think, a lot, there's two things really. One is, I do think, in the spirit of definitions and making sure that the context is well established for a variety of audiences, is the attribution methodology of expenses needs to be more face forwarding than this was in this presentation. So that's not self-evident in hearing how the data was assigned to different categories. The second point I want to make is the point about PM. So I really appreciated Dorothy's point about rate, and PMPM is a form of rate, but it's a pretty blunt instrument as well. And so if you go just one level below, you've got utilization and basically marginal costs. And so for me, I think we need to understand sort of when parts of the healthcare continuum are price takers, like in cases of marginal cost and supply chain, et cetera, and when they're price makers in the case of, say, utilization, and how that influences the cost of care curve. And so really understanding those 2 buckets within PMPM in a more unpacked way, I think would be a really helpful way of understanding this data, challenging this data, improving this data, and making sure the data is actionable. And my third comment, Annalisa, I'll hold for after your public comment sometime later, which is a more general comment for you and others just about the process going forward.
Great, thank you. Are there any other urgent questions? All right. Well, thank you very much, Amy. Appreciate your presentation and all of your responses to our questions. I will remind people that follow-up questions and comments are welcome, and we appreciate that. So thank you again very much, and have a great evening. I assume it's dark now. I hope you get home safe.
Yes, it is very dark, and actually I am at home, so it's great.
Oh, wow. Okay, great. Well, that makes me feel better.
Thank you.
Thank you very much. At this time, I am going to turn to public record. Sorry, I can't ever go the right direction. It's the worst. I'm going to turn to public comment. Now is the time for members of the public to comment on the process and the topics of this meeting. If you would like to make comment, please speak. You may raise your hand. You may speak up. and we will call on you. Public comment, I will pause. If you want to make public comment, I'll remind you to unmute your microphone so that we can hear you. And at this point, I am paused for public comment. I'm asking Serena to let me know if she sees anything in the chat or if we had anybody reserve comment. I'm not aware of that, but I'm going to do a check-in while we wait. Reminder to unmute yourself if you are trying to make public comment.
There is no one signed up and I don't see anyone's hand raised either.
Thank you, Serena. We'll wait one more minute. Okay, I should also check in and make sure that Dr. Judy is here since I seem to be turning to her a little bit early.
I am here.
Awesome, thank you. I am now going to close the period of public comment. However, should you wish to make comment, you're welcome to do so by email or in writing to the board itself, and we appreciate your input. Well, thank you very much for coming to talk to us about our next topic. So everyone, take a deep breath because we're moving from the cost driver analysis to an equally, I think, fascinating topic. And I'm very proud that you're bringing forth the first recommendation. You're here to talk to us about both the primary care transformation model and the primary care definition recommendation. Reminder, the purpose is for these groups to ask questions and make comments for things they'd like the board to consider because they're going to be looking at this recommendation. Judy, am I running the slides for you, or
you are running the slides? Or
I'm going to try so hard to be better at it. So
I am not running the slides. That's all I know.
I'm going to run them. And welcome to the committee meetings, and please let's get started. Thank you.
Excellent. Thank you, Annalisa, and hello, everybody. I think I know many, if not most of you, so I am just going to dive on in with the next slide, please. So first, I'm going to start with talking some about the primary care transformation model, because this has been being worked on for a while. Since 2019, we've been working on it. And while it is closely related to primary care spend, it is not the same thing. And as I've been talking about both of these efforts, we've been realizing that there's a little bit of confusion about that. So I just want to set some context for the primary care transformation that we're doing and talk a little bit about that, and then talk about the primary care spend definition and work, just so it's clear how they fit together, but they don't overlap. So the primary care model transformation, oh, sorry, yes.
No, that's me.
Is a multi-stakeholder approach. So there is a payer table, there is a provider or health systems table, and newly there is a purchaser table, which I'll talk about in a minute. This primary care transformation was one thing at the very end of SIM in talking with payers and talking about how to support rural medicine. This was identified as a topic that needed some work, particularly supporting primary care and supporting behavioral health primary care integration. And so we have been leading this, but we are for sure not the only ones, and there is a lot of work going on. So now next.
Okay.
Yes, ta-da! This is our super nifty slide that is new and updated about how this works. So you can see I'm going to start with the arrow. There are those 4 groups, of which the state is one, that are working together. And we are trying to align infrastructure, standards for primary care, and primary care investment. And for each of those 4 areas or 4 groups that are working on this, there's a little box. And that little box is some of the accountabilities that fit into there. So the first box is, and it used to be a 3-legged stool, now it's a table. We're setting the table. So the first box is the provider accountabilities, and you'll see some nice words in there: whole person care, a team for every patient, care coordination, all the ingredients that we know create advanced primary care. I'm going to go down to the next one. So the payer accountabilities, the payers have agreed, and there are 9 different payers or health plans at the table, and they have agreed to aligned practice supports, some shared quality measures, so that there's alignment there, and then aligned payment, which primarily is going to be led by a per member per month kind of funding that will evolve into that. Continuing to move around the table, the purchaser accountabilities. This purchaser table is a relatively new table of a handful of employers or purchasers in the state of Washington. Also, the Washington Health Alliance and the Purchaser Business Group on Health both have supporting primary care as a priority, and they are at the table for this. And so one of the things that they have a lever in this is aligning their contracts with payers and using that lever to try and continue to have this alignment and support of primary care. And then finally, there's us, the state. And one of the things that we are bringing to the table, besides helping have a space to bring these different tables together, is working on a single standardized evaluation to understand where providers are in their journey of advanced primary care, with one starting with almost little to no progress on advanced primary care. So just starting out all the way to level 3, that they really are an advanced primary care practice, and they're doing a lot of good things that we know supports patients and their families. Next. So those of you that closely follow HCA's decision package, you may know that we submitted a decision package for inclusion in the governor's budget, and we did not get included in the governor's budget. That decision package was asking for transformation funding, so to help those level 1 and 2 practices advance to level 3. And it was also asking for a primary care rate increase to pay primary care more. So that is one of the touch points of where the primary care spend comes into place with this, but it is a separate thing. So while we are not providing funds for that or moving forward on that, since it was not in the governor's budget, we are still continuing to work on primary care, and the provider certification work that we are doing is continuing. And then we do have a number of things that we've been working on to support primary care that ideally are all reinforcing, because we know that primary care is kind of the foundation of bending the cost curve and improving people's health. Next. So this is a nifty little graphic we made because there was some confusion about how these efforts intersected or didn't intersect. So there's a few bullets there about the primary care transformation effort, which is really, as I just laid out, to align payment, incentives, and quality metrics across payers and providers, and is really the goal of promoting and incentivizing integrated whole person team-based care, and is meant to spread across not just HCA covered lives, but across all lives in Washington over time. I think that over time is a key piece. Both the primary care transformation and the primary care spend statute do not have a date by which this has to happen. I've heard rumors that all of this is magically going to happen by January 1st of next year. And I'm here to tell you, we are for sure not getting to done on either of these things by then. Both of these sets of work, besides having the goal of increasing primary care expenditures while decreasing total healthcare spending, is a long-term thing. So I expect that we will be working on this for a number of years before we get to a steady state place. And change is hard. This effort requires change by clinicians, by health systems, by payers, by purchasers, and that takes time. And so we're starting to make that change now, but we won't be done and we won't be to the place that we want to be for a number of years now. But I'm hoping that by having this effort that we start to get there instead of just talking about it. So the primary care statute or primary care spend had 4 things in statute that the committee was entrusted to do. First is to recommend a statewide definition of primary care that I will touch on later. Second is to recommend measurement methodologies for claims-based and non-claims-based primary care. And then last is to advise on ways to achieve and sustain primary care spending targets. The bill did say to get to 12% of primary care spend, but again, it did not give a date by which we all had to do that. So more of something to work on. Now next. So far, the committee has finished recommending a definition of primary care that I think is the next slide. And we've also started to work on the claims-based measurement methodologies. And then the next 2, I think we'll probably be working on for the rest of the year. Next slide. I think we had in the primary care is also an advisory committee to the cost board. And so we heard a couple of presentations about claims-based measurement, what's being done nationally, what's being done in other states. Sadly, there is no one measurement fits all. Every state has done it differently. I think the piece that is common though is all states recommend picking something and then sticking with that for a number of years, because changing it too often makes it hard to compare whether you're making progress or not. We also had a team from the University of Washington do a deep dive into some primary care coding, and they helped sketch out the framework that we're using that includes sort of a who, what kind of service, and a where. So the intersection of all of those 3 circles is what we're calling our primary care measurement. And so we have been starting to work on that. This last meeting in January, we started to work on the who. We didn't get all the way through our discussion, but we did get probably 2/3 of the way through in finalizing both a narrow definition of who is primary care and a broader definition of who is primary care. The broader definition includes things like women's health providers, because for some women, an OBGYN or a midwife is who they go to for their primary care needs when their needs are primarily reproductive in origin and they're otherwise healthy. It also includes providers like therapists, psychologists, social workers who might be on a primary care team and be integrated into primary care, because those services are also important. At the next meeting, we're going to finish our who discussion that is mostly centered around advanced practice nurses and physician assistants. And then we're also hopefully going to get through the where discussion or place of service. And then we are just getting ready to send out a laundry list of codes for the what kinds of services go in there. And I suspect that we'll talk about that in March. And who knows, maybe even into April before we move on to the non-claims-based primary care spend. The next slide, I think, is our final definition of primary care that we are going to present to the full cost board in February. And this definition is an amalgam of the BRIE primary care definition that was made a couple of years ago and the National Academy's definition of primary care. And so this has all the good things about primary care. I'll let you read it, but you know, the team-based, accountable, primary contact, equitable, evidence-informed, continuous, and all the services are coordinated. This is mom and apple pie. This definition, I think, is important to say that we do not intend to put this into statute. There's already a statute around primary care. This definition is meant to be our sort of high-level gold standard for what we mean when we say primary care. And I actually think this is going to be helpful as we dive more into the who and the what in particular, figuring out what services are primary care and does that fit into that or not. So as an example, are immunizations by themselves always primary care, or does it really depend on who is giving the immunization? Is it, say, a family practice doc or a nurse practitioner, or is it an ER doc or a GI, you know, that's giving a tetanus immunization because someone has a bad cut? You know, looking back at this definition of primary care as we think about those specific codes and provider types and place of service will help us, I think, narrow in on what we want to include in our definition, and that's what this definition is meant to represent. Next. Oh, I think I already talked about this, and we are also talking about how social determinant measurement or those pieces fit into here. And then I think, and this was some of the feedback that we got when we presented the definition the first time. I think it is not meant for us to like dive into what does continuous mean, what does team-based mean, but it is really that high level kind of North Star definition that we will look to as we are talking about the who, what, and where of primary care. I think I have just one more slide and then we'll start to take questions, or is this the last one? Oh, nope. This is it, I think. So
this is it. Yeah, I think this is the last one.
Yes. So I think I already mentioned these pieces. The claims-based measurement. We are starting with some of the work that OFM has done, and there still will be narrow and broad definitions that add up. And we think one of the places where social determinants come into play will be with the non-claims-based measurement and the kinds of supports that practices are giving to help people that have social determinants related health needs. So with that, I'll start to take questions, and Louise has her hand up already, so let's go with that.
Thank you. So first, a very quick comment, which is no matter what group gets together, there's always a debate about the definition of primary care. And I would hope that there's not a protracted debate about it, because in the end, I'm not sure that anybody's going to be satisfied with any but the definition that they prefer. My question to you is, why is there any question as to whether or not ARNPs and physician assistants are providers of primary care, since there's a very large number who provide primary care, and even with the healthcare authority's own analysis, half of all Medicaid patients receive care from a nurse practitioner. So could you help me understand why there's a discussion about this?
So it's not about whether they, like, as a whole do or don't. We've just chunked out the conversation as we've gone. So I was hoping that we would get to the advanced practice nurses and the physician assistants, and we just didn't. So that conversation is going, but I will say that there are some advanced practice nurses or physician assistants that they work for surgeons or work for specialists, and there are some that work in primary care. And for nurse practitioners, there's a better code set so that you can tell who is working in primary care and who might be working in specialties. But there isn't a good or as good of a system for physician assistants. And so the conversation is really about how do we use data to help us figure out the practice setting. One thing that the committee has talked about is that urgent care and ER is not primary care. And so we want to identify people that are working in true primary care practices. And so that's the discussion. It's not that they don't do primary care, because I absolutely agree there's a large chunk of them that do. And so the question is how do we figure out which part of their work goes into the measurement piece? Does that make sense?
Yes, because this was part of the consideration when the OFM report was constructed. And it seems to me that part of what has to happen is some change in the way that data is collected so that the data is better. Because I can't exactly remember, but you can have a physician who works in primary care, a family practice physician who works in primary care, or a family practice physician who works in urgent care. So if you can differentiate between their settings, however you can do that, we ought to be figuring out how we collect that data on ARNPs as well, or physician assistants, so that there isn't this challenge every time we go looking for the data.
Yes, that is definitely a part of what we're going to do. And that's why we have those sort of intersecting circles of the who, what, where that I think will get us to a little bit more of a precise definition. Louise, I know you were on those OFM phone calls, and what we ended up doing was that 60% of physician assistants were primary care. And I am hoping that we're able to get to a little bit more of a defined ability to sort of figure that out rather than do a percentage. But it is challenging. And once we get to the non-claims based spend, I think that will be even more challenging. But we have some experts lined up and some people who've thought about this that I'm hopeful will give us some good advice about where to go.
Thank you. I appreciate that.
Yes. Brittany?
Yes, you brought up something that was kind of interesting to me about urgent care. So I know that urgent care is expanding, especially in my community, just because urgent cares are open longer hours. They're more accessible than regular clinic appointments. And now urgent cares are providing annual wellness visits, as well as other services that I would associate with primary care. So I'm just wondering why urgent care, since it's kind of going in that direction, is being excluded from being considered primary care, and would there be any situations where then urgent care would be considered primary care?
Yes, that's a great question. And I should say that those comments I made earlier about urgent care and emergency room care were comments that the committee made at the beginning of their work. We have not yet gotten to the setting place, and I suspect we will have a robust conversation about setting and whether urgent care and ER visits get included, or if there's places where they might. So the only part of the definition, which is a tiny part that we've gotten to so far, is the physician, actually a naturopath, because we had that discussion already of who fits into primary care. And so there is a lot more to go. And as the committee works on our definition, we will get back to you with our further discussion. I don't know, Annalisa, are we scheduled to come talk every time to give this committee an update on the other committee? I know there's a fair bit of cross-pollination.
Yes, almost every time, Judy, and very frequently at the provider and carrier committee. So you'll be coming back,
Yes.
either you or someone.
I will come back. That's
A
right.
lot. You guys will be good
Yes.
friends.
And there will be much more discussion. And certainly, like these committee meetings, the primary care spend committee is an open public meeting. And so folks are welcome to come join and give their thoughts, and that would be great.
Are there more questions and more discussion? I'll remind you that the context is that this is going to go to the board, at least the portion about the primary care definition recommendation is going to go to the board, and they're going to discuss it and consider it. So let me ask you, are there things that you think the board should keep in mind or consider or ask Dr. Zerzentul when she presents to them? Okay, well, it looks like people have asked you what they wanted to know, Judy, and I appreciate very much you coming, bringing this recommendation for them to look at and consider. And we look forward to your continued work on this really interesting and important topic. So thank you so much for coming.
Oops, I put myself on mute. Great. Thank you all. And I will talk to you next time. Have a good afternoon.
All right. Thank you.
Bye.
Well, that brings us to the end of our agenda, a little bit early. I am mindful, Mike, that you said you had a comment that you wanted to make. I know we have a little bit of time, so yes, I see your hand. If you wanted to do that, or if anybody else has a last question or comment before we adjourn. Mike.
Thanks, Annalisa. Yeah, this is a little bit off the agenda, but it's certainly not off topic relative to our work together. I thought that recently I've been made aware of some legislation that is under consideration for this legislative session. And depending upon whether the legislation pass and what it looks like and how it is implemented, has implications to, I think, how we process our feedback to the board. And I don't know how the timing works, but I know that I would really benefit from the contextual understanding of that legislation. I'm not talking about to the gnat's eyebrow, but the contextual understanding of that, because it would influence the urgency or specificity or emphasis depending upon what this new legislation, this whole process has started from a legislative action that took place a while ago. And now there's new legislation being introduced on top of this that is material to how we think about our work relative to how we would offer up recommendations. For instance, just one example I'll give, and then you can think about this. Annalise, you've been really consistent as you've talked about the iterative and generative nature of this journey we're on together. And even earlier today, you said something akin to, the benchmark around these cost drivers and the inflation rate is not a scarlet letter. It's the beginning of a conversation, I think, is what you said. And yet, for instance, in House Bill 1508, very significant fines and penalties are intended to be implemented on providers as soon as 2025. And so just again, I feel like I'm missing a part of the puzzle when I think about where this body, the trajectory this body of work is on. And so I know that, we're in a administrative body right now. We're not in a legislative body right now. So I don't want to mix apples and oranges at all. But I do think that what's under consideration is material to how we think about the kind of guidance we might be offering the board within their deliberations. So I would personally find it beneficial if some of the legislation is still under consideration or maybe even passed by the next time we meet, if we had just kind of an overview of it in its relationship to the first legislation, which we've been offering thoughts about and participating in for some time now. That's it.
Oh, great. Thank you, Mike, for bringing that up. For those of you who are not following what is happening in session, there is a bill. Mike mentioned the bill number. I'm not going to repeat it because I might get it backwards. And it was brought, I believe it is sponsored by consumer advocates. It had a hearing at the House Healthcare Committee, and it does involve some additional reporting that would become the responsibility of the cost board, including a report on underinsurance, some other things, and the suggestion that there should be some enforcement mechanisms, for want of a better term, that similar to some that are in other states involving improvement plans and penalties. So what I'm hearing is a request for a discussion of that bill. It felt a little premature to do it now because it hasn't gotten very far. I think that summary is all I intend to give to the board, just in case anyone there is not following, so that I invite you all to look. Healthcare Authority signed in, testified on that bill, but I believe signed in with other as a position. The agency is not supporting that bill specifically. So I invite you all to follow that process of the legislature. And of course, Mike, your point's well taken, that would be a significant new direction from the legislature for a few new responsibilities, including the possibility of some different consequences for the benchmark than are currently contemplated. And we would have to grapple with that and discuss that as a board and advisory committees and as an agency. So point well made. And
Right.
Again, so at the board, I'm just going to bring it up very lightly. I will have the correct bill number and simply mention it to them. I'm not going to even include a copy in the
My
materials.
suggestion, just so I'm clear, Lisa, I want to make sure that I'm clear with you. My suggestion is nothing to do with your upcoming meeting with the board. I mean, you're welcome to make the comments you just said, but I'm more interested in the next time we meet as an advisory group, which, maybe a few months from now. I'm not even sure when the next time we meet, but let's say, and to the extent that this bill becomes a law, then I'm just suggesting that there should be some orientation to it, because
Right.
the frame of reference that it introduces is different than the spirit of at least the comments that I've heard previously. And so if we are operating under a different set of assumptions come 2-3 months from now to be implemented, starting in calendar year 24, we should just have someone give us an overview of what that looks like.
Understood. Absolutely, that will happen. And the next time we meet is before the end of session. So it might be the one after that, but I will take responsibility for that for sure. Thank you, Mike, for bringing that up. Are there any other comments or questions, concerns? All right. Well, thank you very much for everyone attending our first advisory committee, our first joint advisory committee, and our first advisory committee meetings of the year. I always appreciate your time, attention, and the fact that you volunteer to bring your expertise and help this important effort stay in the right direction. And with that, everyone gets 10 extra minutes in their day. I know you're all extremely grateful. Have a wonderful afternoon. Thank you.